A small conference was going on.
Okay.
Manoharan sir is there.
Sir,
Good evening, sir. Good evening, sir.
good evening, everyone. Everyone's video on, everyone stand by. We are live in 5, 4, 3, 2, and 1.
Good evening, everyone. Again, we are having live session through our SRB Surgical Insight YouTube channel. I welcome for the session. We are discussing about thyroid examination, thyroid malignancy. I welcome Professor G.V. Manoharan sir. He will join in 5 minutes. He has messaged me from Puducherry. I welcome my dear friend Dr. Robinson from Teruvella. I welcome Dr. G. Muthukumaran sir, senior professor from Savita Medical College, Chennai. I welcome my dear friend Professor Sunil Subhash Joshi from Chikkaballapura. Welcome all of you. I welcome my dear friend, very close friend, Professor Keshav Prasad from Sulya. He is in Mangalore, Sulya Medical College. All of you, sir, faculties, a warm welcome to you all. Again, I welcome today's presenter from my college, Keshav Prasad Medical College, Mangalore, Aryan Shetty and Abhishek, final MBBS students from KFC, Mangalore, and all viewers and students, and welcome everybody. Sir Robin, Muthukumaran sir, Keshav, and Sunil sir. Without wasting time, I think we'll go ahead with the presentation of the day.
Yes, sir.
Manoharan sir will join in 5-10 minutes, he has told. We'll continue the presentation. Over to
Good evening, sir. Good evening, sir. Joined.
Sir, joined, sir. Thank you, sir. Sir, welcome. My
Good evening, sir. Good evening.
most welcome to you, sir. He's my very senior member, my rather inspiration to me always, sir.
Old man, sir. That's all. Nothing else.
Your inspiration to me, and
Yes,
sir,
sir.
I sent a forward to my 8th edition book.
Muthukumar.
Good evening, Manoharan sir. Good evening.
Good evening, sir.
Good
Muthukumar.
evening, Manoharan, sir.
Sunil, sir.
Good evening, sir.
Good evening. Good evening. Namaste.
Sir, welcome to you, sir. Very much welcome to you, sir.
Yes,
So,
sir.
sir, we'll go ahead with the presentation for the students.
Yes, sir. Yes, sir. Please.
So, over to students. Abhishek, you are presenting, no?
Yes, sir.
Start.
Good evening, everyone. Today, me, Abhishek, and Aryan of Kasturba Medical College, under the guidance of Dr. Sriram Bhat, sir, we are going to present on the topic examination of neck swelling, that is thyroid malignancy. So, coming to the patient particulars, it is Mrs. X, a 61-year-old female homemaker from Kadur, that is in Chikmagalur district of Karnataka. She came to Government Venlock Hospital on 21st February 2026, and we examined her on the date of 22nd February 2026. The chief complaint of the patients were swelling in the neck since the past 2 years and difficulty in swallowing since the past 10 years.
Lights are
10
not
days,
seen.
sorry. History of presenting illness. The patient was apparently asymptomatic 2 years ago when she noticed a swelling over the anterior aspect of her neck. The swelling was insidious in onset, initially small in size, and gradually progressed to attain the present size over a period of 2 years. It was associated with difficulty in breathing, which started approximately 1 year ago. For this complaint, she sought homeopathic treatment. However, there were no significant relief of the symptoms. The patient complained of difficulty in swallowing for the past 10 days. The dysphagia was more pronounced for solid foods than for the liquid foods items. It was associated with nausea and excessive salivation. There was no history of any pain during swallowing, that is, no odynophagia was present. There was no identifiable aggravating or relieving factors for dysphagia. There is history of hoarseness of voice present, history of significant weight loss present, history of heat intolerance, and history of excessive sweating is present. There's no history of tremors, increased protrusion of eyes, and there's no history of loose stools or constipation present. There's no history of fever, discharge from the swelling, any discharging sinuses, over the swelling. There's no history of pedal edema or any kind of abdominal pain. Past history. The patient is a known case of hypertension in the past 4 years and is currently on medication and is compliant with the medication. There's a history of thyroid surgery done 30 years ago. The patient is not a known case of diabetes mellitus, tuberculosis, asthma, COPD, epilepsy, chronic kidney disorder, cardiac disorder, or any other comorbidities. There's no history of any other previous surgeries or any tubectomy done. There's no history of any previous blood transfusions in the patient. Coming to the menstrual history, the patient attained menarche at the age of 13 years. The patient had regular cycles of 30 days length in which the bleeding lasted for 2 days and she changed 2 to 3 pads per day. She attained menopause 20 years ago. Coming to the obstetric history, her obstetric score is para 2 The last pregnancy was 35 years ago. Her first child is a 38-year-old female and second child is a 34-year-old male. Both the deliveries were normal vaginal deliveries without any complications.
We are not able to see the slides. Is anyone seeing the slides? Okay.
Able to see,
Coming
sir.
to the family history,
Please, sir, we can
patient,
continue.
coming to the family history, patient's niece had a thyroid surgery done 25 years ago. Patient is the second of 4 siblings. She has one elder sister and 2 younger brothers, and she is married with 2 children. Coming to the personal history, patient consumes predominantly a non-vegetarian diet. Her appetite is normal. Her sleep is adequate. She is not on any regular medications. Her bowel and bladder habits are regular. There is no history of any alcohol consumption, smoking, or any drug abuse. So, coming to the summary of the history, a 61-year-old female homemaker presents with complaints of swelling in her neck. The swelling is insidious in onset, previously small in size, gradually progressed to current size during the course of 2 years, and is associated with dyspnea since the past 1 year. The patient developed dysphagia 10 days ago, which was more towards solid food items. It was associated with excessive salivation.
I'll go back to the sir. Anything to comment on this, Manoharan sir, Robin, Keshav, Muthukumaran, patient,
Elderly female.
elderly female. Yes, sir.
That is one elderly female. Right.
Next slide. Next slide. Next slide.
Abhishek, next slide.
Abhishek.
Yes, sir.
Next slide.
Second is a little bit endemic also for thyroid disease.
Anything in this? Yes. This is there anything to comment on that? Next, you can go to next slide.
Next slide.
Yes.
Okay. You said efficiency will take 2 years ago, procedure swelling, and reach the present size in 2 years. Difficulty in breathing and so 1 year he's got difficulty in breathing. That's what he is telling, sir. And homeopathy treatment, no significant relief of this. Robin, anything to anything to add on for the blood pressure?
Exactly, he needs the difficulty in breathing. So this is not that. So what exactly is what is the difficulty in breathing? If you are having breathlessness, if you are having what exactly is this difficulty in breathing?
So that breathlessness, any detail you have asked, Abhishek?
So while taking the history, we tried to grade the breathlessness based on the MMRC classification. Initially, it was grade 0 2 years ago. Like she started developing grade 1 MMRC breathlessness. Then it progressed to grade 3, sir, during the course of 1 year.
Do you think this is related to thyroid or something else, sir? Do you think it is related to thyroid or something else, whether cardiac, respiratory, or anything else?
So it might have many causes. It might be the thyroid gland only, which might be compressing the trachea, or it might be any respiratory or any cardiac cause that might be causing the
So that means you are
breathlessness.
telling this is a strider. What is strider?
Stridor is the sound produced while breathing.
You are purposely vague. It is actually compression over the trachea. So,
Compression of the
oh,
trachea, sir.
okay. Robin, anything to comment on that?
No, it's fine, sir. Only thing is, we wanted to know the evolution of the breathing difficulty.
Yes, that's
Surgical versus medical. As sir has just asked, surgical or medical?
Yeah,
We want to know that.
whether it is related to this swelling or it is something else other than swelling. So they should clearly differentiate by taking proper history.
Exertional, non-exertional dyspnea, basically medical from surgical.
That is important by telling about the breathing history. So next slide. Dysphagia more pronounced on solid food than liquid. What is the reason for that? What it meant for you?
So she didn't have any pain, but the solid food that she was consuming, she couldn't swallow it properly. Like the liquid, which is smooth to pass through the trachea, was able to pass. So,
Okay, but
by this we can deduce that it might have been compressing the esophagus also.
you are telling this swelling is compressing over the esophagus. That's why patient is having dysphagia for the solid.
Yes, sir.
Anything to comment on that, sir? Manoharan sir, Kumar sir, like just evaluation of the year.
Abhishek, do you hear me?
Yes, sir.
Yes, yes, sir.
So when patient has two complaints, no? First is one is you said breathlessness.
Yes, sir.
Then now you say that there is dysphagia. Am I right?
Yes, sir.
So first thing, if there is a huge enlargement of thyroid, which comes first?
Sir, based on the chronicity, sir.
Yes. Tell
So
me.
since the swelling is more, it has been evolving since past 2 years.
Yes.
That should be the first this thing. Then the second complaint should be the breathlessness, since she is having it since the past 1 year.
No,
And-
Abhishek, it's actually simple,
That
sir.
is what-
Question is simple.
exactly, I'm asking that only.
Yeah,
What is
which one
immediately
comes
behind the thyroid? What is
Yeah, anatomy is the question. That is sir's question. This is a straightforward question.
yes, sir. Trachea is just below the.
right? If trachea is what it is made up of?
So it is made up of the cartilaginous rings.
So when you press the trachea, what will happen?
It will compress.
No.
The rings will.
No, it will not collapse.
It will not collapse because of the
So when
cartilaginous
you
rings.
give pressure, it will go back. What is behind the trachea?
The esophagus, sir.
So what happens? So what will be the first symptom then?
It should have been dysphagia.
Dysphagia. Then classically you are telling initially not able to swallow solids and it's comfortable with liquids. So what is behind the esophagus?
Aryan, you can also answer in case. Okay.
What is behind the esophagus? Arya. Yes.
Vein.
Cervical spine.
Yes, sir. Spine.
Understand? So when you give anterior pressure from the thyroid, it will go and push the trachea and trachea will go and press the esophagus.
Spine.
When you trachea gets compression, what should be the type of growth? something which is narrowing the trachea. The last you said no. So what type of growth must be there?
So infiltrative growth into the trachea.
You understand that initially if you push the pressure on the neck, first structure to collapse. Unless you compress the trachea from the side, it cannot become narrow. You just press it anteriorly, it will go back and press the muscular structure, which is a tube. So it is easily compressible. Understood?
Yes, sir. Yes, sir.
So how do you explain this? How do you explain this one more pronounced with solid foods than liquids?
So, as solid foods require a large lumen to pass through, I guess the compression is not the lumen is not fully compressed, and liquids are easily to pass through the lumen. So she is having dysphagia more towards the solid component of the food rather to the liquid component of the food.
It's a little bit elaborated on what is the dysphagia business. Exactly that you mean to say. Your history is correct. You have done an excellent presentation. But dysphagia means what exactly the patient says in her own words.
The patient said that she couldn't, like there's no any pain as such while swallowing the food. She can drink water properly, but when she's having breakfast or lunch or dinner, she has a difficulty to swallow the food. She feels like something is compressing, and she's not been able to swallow the food per se.
Right, accepted.
Aggravating relieving factor.
Sorry, sir, I couldn't hear you.
What is that aggravating and relieving factor? Which one you are looking for?
Sir, aggravating and relieving factors for the dysphagia is like anything. If we asked if anything, if she does that relieves, like if she can swallow food properly or something.
Anything to ask, sir? Muthukumar, Robin, sir, Robin.
Having mentioned, what is this odynophagia?
Odynophagia is pain during swallowing, sir.
Yeah, tell me some conditions which can cause odynophagia.
I couldn't hear you, sir.
Conditions which can produce odynophagia.
Conditions, sir.
Benign causes, malignant causes.
Painful swallowing, that's all. So conditions.
So it might be due to any infection such as tonsillitis. Then we'll have pharyngitis as such. If there are any odynophagia, might be related to GERD, that is gastroesophageal reflux disease.
What about esophagus? Esophagus, you talk about
Carcinoma esophagus.
either benign condition, first said given hint already.
So, any esophageal cancers.
Candidiasis.
Candidiasis.
Candidiasis can produce painful. Okay.
Joshi, sir, you can see the slide now, sir.
Yes, I can see it, sir. Now
Thank you, sir.
I was away for a call. I came back now.
Yes, sir.
Next slide, sir. Next slide.
Next slide, sir.
Next slide, Subisha. Why hoarseness of voice?
Sir, any involvement of the recurrent laryngeal nerve.
Okay. White loss, white loss.
Yes, sir.
Why hoarseness?
Weight loss.
Couldn't get the question.
Weight loss. Why weight loss?
Weight loss, it might be due to increased levels of T3 and T4, or might be due to the That is toxicity and or else any malignancy.
Okay. Okay. Heat intolerance.
Well,
With the available history, what do you think it is?
So available history, we can deduce it as since the swelling is so diffuse, we can know it as multinodular goiter
No.
or carcinoma.
It is whether it is benign or malignant.
So
History,
benign.
weight loss.
You only said infiltration of the nerve. You only weight loss. Sir asked to correct exactly. What is the reason? If it is malignancy,
There will be significant weight loss, more than 10% of the body weight in the past 3 months.
exactly. That is what the answer should be. If you think it is malignancy, what other kind of signs of malignancy in thyroid? Some other features?
In thyroid malignancy.
Hoarseness, weight loss, anything else?
There will be increased appetite, sir. There will not be loss of appetite.
No, that is you are talking about hyperthyroidism and toxicity.
You are talking about hyperthyroidism, malignancy.
Malignancy we are asking. Thyroid.
Thyroid, hoarseness of voice.
Your history says within how long that swelling has grown?
So within 2 years, sir.
2 years. So
Within the course of 2 years.
She says within 1 month it has become double, triple. What does it mean? Possible
It
not
might be malignant.
rapid increase in size.
rapid
Malignant, sir.
Rapid increase in size.
That is, you are not mentioned anything about the recent rapid increase in the size.
That history, did you ask?
So we asked for the how did the swelling increase? The patient said it increased slowly within the course of 2 years.
Correct. But within the recent 2-3 months, whether there is further increase.
No, sir.
That
We asked.
Specifically, you have to ask.
dramatic increase.
Dramatic increase. That you have to
Yes, sir.
specifically ask. Okay.
Yes,
So
sir.
what is this excessive sweating present? Tremors?
So tremors and excessive sweating and heat tolerance are signs of toxicosis,
Okay.
hyperthyroidism. So
Okay.
there's
Correct. But this heat intolerance and excessive sweating which you talk about, you need to tell us when she has noticed it. Has it been from last 2 years or whether it is recent change?
Duration.
it's a recent change, sir.
So you'll have to mention about since when it has changed. Too many things seem to have changed in the recent past, isn't it?
Yes, sir.
You mentioned so many complaints. You have not mentioned the duration of the complaint, as Sir said. One more thing is, it is not in a particular
Order.
order.
What is
If you want to rule out toxicity, mention symptoms related to toxicity. Then you can go to malignancy, or based on the age, you can give importance to malignancy. Then you can mention about toxicity.
What is the duration of the hoarseness of voice, Abhishek?
Hoarseness of voice is since past 1 month, sir.
That you should
That
have
is significant.
it also.
Very significant. Now, latest development.
Yes, sir.
All these days she was not having any hoarseness, and from last 1 month or 2 months, whatever you say, she has got hoarseness. That means something is going on there which is changing the whole picture.
Yes, sir. Yes.
Yes,
That's
sir.
right. That's true. Absolutely right. So better to put the duration you have to mention, and you have better to put the chief complaint, because in a thyroid, when the hoarseness of voice should come in the chief complaint also. And duration, like Sir Muthukumar sir told, duration of these things are important. You'll have the fair idea, like Sir sir told, no, or something pathology, some specific pathology is going on.
Yes,
You'll
sir.
get the idea about that. So duration is important. In orderly fashion,
And
probably
yes,
important.
and usually these are the things which bring a patient to the hospital instead of 2 years ago, instead of a year ago.
This one.
Yes, sir.
Correct.
All these things you must mention in your chief complaint with the duration.
Yes, sir.
Instead of 2, I think you have to mention over 6 or 7 complaints.
Yes, sir.
That's true.
This last 3, history of tremors, negative history, increased protrusion, negative history,
What is increased protrusion of the eyes now?
Exophthalmos.
Has
it's
it been
a thyroid
present
eye
throughout?
sign.
No.
Protrusion is okay.
Is
What
it
is
present throughout, which has become increased now, or is there normally a protrusion of the eye?
There is no history, sir. The eyes were normal,
not
sir.
getting
There's
my
no
point.
increase.
No.
Protrusion is a
Protrusion is different. What is that increased protrusion? Sir is asking.
Normal protruded eye as a congenital anomaly will be there. Otherwise, Protrusion of the eye itself is not normal.
So no, just put no protrusion of eyes.
Yes, sir.
You put an adjective that the whole thing will change.
There is protrusion of a grading may be there. I'm not sure. There is nothing like increase. You tell clinically protrusion of price present or not. Understood, Abhishek? That's what all faculties are informing you. Okay.
Yes, sir.
Protrusion of eye present or absent. That's the only thing. Okay.
What is the last point? History of loose stool
Diarrhea.
or constipation. Both.
Both you mentioned.
Both.
Importance of loose stool, importance of constipation, tell me.
Loose stool, when you will get loose stool in relation to thyroid, when you get constipation in relation to thyroid.
So in hyperthyroidism, we might have loose stools. In hypothyroidism, we'll have constipation. Sir.
So which malignancy you will have loose stools?
So differentiated thyroid cell carcinoma.
Which one?
Which one?
Papillary, sir.
No.
Medullary.
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 That produces GI symptoms. Okay.
Yes.
MEN.
Next slide.
Next slide. No discharge from the swelling. Why discharge from the swelling? Sinus. Pedal edema. Why discharge from the swelling? Specifically, you ask.
Discharge from the swelling for low rolling out any thyroiditis or any.
No, thyroiditis is an inflammatory swelling. Will you get discharge?
It may cause pain and fever, but not discharge. Discharging sinus, discharge from the swelling you are written. So keeping what in mind, you have mentioned this history specifically thyroid, or keeping something else other than thyroid also. Are you keeping in mind as a differential diagnosis?
So any abscess formation or
No. Abhishek, what are the differential diagnosis of a midline swelling?
midline swelling?
You start from top to bottom. It's very easy. Anatomically, you go down. What is the most common swelling in the neck? First.
You know,
It's the thyroid.
No.
midline and
That is most common swelling in the neck.
In the neck, sir.
in the neck only.
In the lymph, any lymph node, sir.
Any lymph node. Okay, that's it. So you start from level 1A, B. No, so submental, so lymph node. Then you go slowly downwards. What else will you get here? What other differential diagnosis?
From above downward. Midline swelling. That's how it's classified. No, neck swelling, midline, lateral. So Robin sir is asking, what are the midline swelling you think of from above downward? Just imagine.
In an exam, whenever you say something, examiners will catch on to that point. So discharge from a swelling, you have a clean swelling. There is no opening, nothing in the midline. So why would you want to do that? Okay,
Yes,
like SRB sir has asked, is there any swelling here that may present with a discharge?
Discharge.
Is it possible? A midline swelling, there are swellings in the midline and lateral also. Can you just give us midline?
Midline.
There are few bony structures here. HTC, thyroid bone,
Thyroid.
thyroid cartilage and
Thyroid
clitoris.
and
So
thyroid cartilage.
anything related to the top level?
So any effect in the thyroid.
You can, yeah.
So fistula, thyroglossal,
Very good.
What about a thyroglossal cyst?
infected thyroglossal.
Simple cyst.
Simple cyst.
It becomes a fistula because you have done something inadvertently. You have not treated completely. You have caused a fistula. So it's a very simple thing. Nah? Then you have subdermoid cyst, subhyoid dermoid cyst, and then you go down to the thyroid swelling. Then you go down to lymph node again. Simple. It's very easy. Be very careful when you put these points. It's a clear-cut case. Discharging sinuses again midline, or would you see it commonly somewhere else, maybe lateral side?
So lateral is
So
more
what
common.
do you think of there as differential diagnosis that cause discharging sinuses?
Neck.
Any lymphoma, sir.
Lymphoma, discharging sinuses.
Sinuses.
Common condition. Infective condition.
Abhishek, whenever an examiner asks you, it's a very foolproof method. You go very simple things, you'll be correct. You go for rare things, you'll rarely be correct. Benign things, malignant things. These
Any
are-
sebaceous cyst.
Huh?
Any sebaceous cyst.
Sebaceous cyst, how common is discharging sinus?
Common disease.
Some common disease, a common infective condition, specific infection. Something common in this developing country.
common to India.
Country.
We have-
TB.
TB.
Abhishek, it's very easy to remember this. when they came here, they took our Kohinoor, so we wanted to give something back. We gave this.
Tuberculosis lymph node, no? For the lateral.
The West never had tuberculosis. We introduced TB to them.
Tuberculosis in any neck swelling, don't forget tuberculosis because it could be. That's the point you remember always.
Yes, pedal edema. Okay, what do you call this pedal edema? Any particular name?
Mixed edema.
Mixed edema.
No, any particular full name, full. Is it pre-fibular, pre-tibial, something like that?
What is
Pre-tibial mixed edema.
Is it a pre-tibial mixed edema is a feature of hypothyroidism or hyperthyroidism?
Hypothyroidism.
Hypo? Pre-tibial mixed edema? Aryan?
So, primary thyrotoxicosis.
Correct.
It is a misnomer. Be very careful. Yes.
It's a misnomer.
What is the clinical point to say it is mixed edema? Somebody has got a edema. We don't know whether it is mixed edema or something else. So what do you do to confirm? Clinically.
And it is common this
Non-pitting edema.
non-pitting edema.
All edemas you have, every edema you put your finger, you will feel that pitting you can see. Edema, you don't get the pitting. So non-pitting edema is mixed edema.
In front, lower leg, foot. That is the area where pre-tibial mixed edema occurs. Usually it is bilateral. Related to the primary thyrotoxicosis, not hypothyroidism, Abhishek. It's a
Yes, sir.
toxicosis. Okay, it's a misnomer. So abdominal pain, why you ask?
So anything related to constipation or diarrhea.
No, you. Why? What is abdominal pain? Will have constipation, diarrhea.
Do you think
You already mentioned that before. Symptoms you already mentioned to us. Why you want to do that? Is there any other condition? See, the point is you have positive findings. Now all no is your differential diagnosis you're trying to rule out. You're given us probably points in favor of a malignancy. So is there anything else that can lead you to an abdominal pain?
Abdominal pain and relation to the thyroid or something, just like asked, or there is a specific reason to ask this one.
Patient already has hoarseness of voice.
Patient has severe diarrhea.
Any secondaries?
Where? Colon.
Second is the colon, second is somewhere where?
Colons.
Oh, yeah.
Abhishek, your imagination is running wild. So unnecessary things you put negative history, you unnecessarily lead these questions. Your case is primarily thyroid. You are leading us going this side, that side. That last point is unnecessary, unwarranted, I think. You should remove.
Unless a specific reason, there is no, because
Please you justify, I asked this question for this reason, that you can put it up, it will be nice.
Because finally at the end of the day, you should be able to give reason for whatever you are writing.
You write a case sheet and submit to us. We will go through each and every word you have written and given. Written proof. We will ask now why you have written this.
You should be able to give reason, justification.
For what you have written. Next slide, sir.
Abhishek, just to complete that one sentence what sir has said, please note, if you are thinking of malignancy, you know the classification of malignancy, DTC and non-differentiated. So the clue is you should know papillary, where does it spread to metastasis? Follicular, where does it spread to? Anaplastic, where does it spread to? Medullary, where does it spread to? Lymphoma secondaries. These are the common, easy ways to remember 6. Of this, yes, 1 goes to liver, not to colon. So you should know which one goes to where. Yeah.
Yes, sir.
For your NEET exam, you should know this.
Yes, sir.
Yeah.
So we'll go to the next slide, sir.
We'll go to next slide. Yes, sir.
Next slide.
Sir, 1 second, sir.
Yes, sir.
Thyroid surgery 20 years ago, whether it is relevant now?
Sir, I want to stress one point. Am I audible?
Yes,
sir.
sir.
Yes, sir. Yes.
Sir, please.
See, it is a case of probable malignancy based on the hoarseness of voice. Hoarseness is a local effect of malignancy. What about the distant effects of malignancy? Thyroid malignancy. If it is thyroid malignancy, it can have metastases. What are all the possible sites of metastasis? You tell me.
So this, have you asked about the swelling in the skull or bone pain, respiratory problems?
Yes, sir. It's there in
Yes, sir,
exam.
we asked.
Skeletal metastasis is common.
If you think
Lung
that
mets you can get. As sir said, liver mets you can get.
Lungs, bones,
Sometimes you can
liver,
get
and
brain mets also.
brain is rare, sir.
And
Last brain.
skull is there, no? Skull is very common side.
Yes, sir.
So all these things we
Skull
have
and
to cover.
vertebrae.
You talk
Yes, sir.
about local effects of malignancy, you talk about distant effects of malignancy also.
Whether this
Yes, sir.
thyroid surgery is currently related to current problem or not. 30 years back thyroid surgery. Abhishek,
So it was done 30 years ago, sir.
So what are the details? Why they did? What surgery has been done?
So she
Yes.
couldn't deduce the history for that, sir. She
Okay.
didn't
No,
know.
simplest things you could ask is what was the reason she went to the doctor? Was it only for the swelling or she had any other problems? And what did the doctor say after the surgery, that it's cured or it is treated completely? What was the information like?
Like we tried to deduce the information about the surgery done. So she didn't even remember the history. So when we saw the scar over this thing, then she remembered like, yeah, something had happened 30 years ago. Something they told. Like she didn't remember what.
Maybe thyroid, may not be thyroid.
Yes, yes.
Maybe
But
thyroid, may not be
she
thyroid.
used the words thyroid. So
Where was the surgery done, Abhishek?
yes, sir.
Where was the surgery done?
At a government setup, sir, in
Yeah,
Chikmagalur. Chikmagalur only.
30 years back in Mangalore, huh?
Yes, sir. She said the same thing.
No, she is 67 now. 30 years back means she must be 37. She is not child.
Yes, sir.
At that time she is married and she has children and all that. Definitely she will knowing something, isn't it? Probably didn't elaborate much about it. Okay.
Radiation therapy history is also important.
Yes, yes.
so whether she was mentioned, she was told whether it is malignant, benign, something, whether you should ask in little more detail about thyroid surgery, and if he remembers at least, that's important.
Is he on any medications?
Surgeries, you said, having told that thyroid surgery, why you have put as a no other previous surgery and other. Okay. Why tubectomy you have specified? Any reason, or just routinely you asked, or they just asked?
This thing, sir.
That will
Is she on any medications?
She is on she's taking medications for hypertension, sir, since past 4 years.
No, whether
not on that, no thyroid drugs.
No thyroid drugs, sir.
Whether she is taking thyroxine because having removed thyroid.
No, sir, no thyroxine.
So that means what?
It might be a hemithyroidectomy.
It might be hemithyroidectomy, or a olden days they used to do partial thyroidectomy.
Partial thyroidectomy.
Manoharan sir, we also know we used to do that at least 25 years back. Robin might not know. I think we were doing it 30 years back.
Yes, back.
Subtotal.
We used to do partial thyroidectomy. I think Muthukumar sir will be knowing.
Yes, sir.
Subtotal thyroidectomy.
Subtotal.
Total and partial we used to do.
Partial.
Not done anywhere.
Abhishek.
Yes, sir.
What is this previous blood transfusion to do with this?
Why
Sir,
business
for this-
transfusion history?
Past history, I have asked about blood transfusion. What is the relevance?
In this patient, what is the relevant? Why you want to specifically ask? To get any information you want to get, or routinely you ask?
Sir, routinely.
That's why all the hysterectomy is blood transfusion. Whether it is relevant to this current problem, or you ask as a routine history. You should be able
It's a
to
routine history, sir.
tell them.
Too many routines, it does spoil the case. You have got good findings, good discussion. Unnecessarily you brought all these things, previous blood transfusion, all that. Don't worry. Next slide.
So next slide. So thyroid surgery detail, if you're able to get, that is a good thing actually. Post thyroid, what exactly happened? Probably rightly you are told, because patient is not on L-thyroxine. Mostly they have retained some part of thyroid. It is adequate enough to maintain the thyroid function. Probably hemi, all the olden days, people used to do what's it called as a partial thyroidectomy, which is not done now. So next slide. Abhishek, next slide. Okay. Sir, anything to comment? This one.
We'll proceed, sir. We're already still in the history.
Next slide.
Okay. Next slide. Next slide. Family history. Okay, yes. Thyroid surgery done 25 years back. Thyroid surgery. Family history. Okay, next slide.
Abhishek, just we will not waste time because it's 8:40. Just to complete family history, please be very careful of that when it comes to malignancy thyroid. There are at
Yes,
least
sir.
5 syndromes of this. You should know at least 2 if somebody asks you. Okay, we will
Yes,
not
sir.
waste time. Yeah, you should know at least 2 because one of them is completely related to thyroid
Yeah.
and other endocrine system.
Yeah.
Yeah.
Yes, sir.
Cowden syndrome and Egan syndrome
Cowden syndrome, Carnage complex,
we asked
men 2A, men 2B syndromes.
for what of time we are going. Next slide.
Yes, yes.
Next slide. Submission, next slide. Okay, we are not going to discuss this one, alcohol consumption, bowel habit. Next slide. Next slide. Summary, again, same thing he has told, sir. Yeah, and other things towards food diversity to the excessive salivation. We could not identify why it is so. That I will discuss later. So we'll go for the presentation, sir.
Yes, sir.
So Aryan, next slide.
Yes, sir. So, general physical examination. Consent was taken. Patient is conscious, cooperative, and well-oriented time, place, and person. Moderately built and adequately nourished. Weight was 74 kgs. Height was 158 centimeter. So, BMI was 29.6 kg per meter square. Vitals, coming to vitals. Blood pressure was 154 by 84 millimeters of mercury in right arm sitting position. Pulse rate was 78 beats per minute. Regular rhythm, adequate volume, normal character. No radioradial delay, no thickening of vessel wall, and all peripheral pulses were felt. Respiratory rate was 16 cycles per minute, thoraco-abdominal. Temperature 98.6 degree Fahrenheit at the time of examination. There's no signs of pallor, icterus, cyanosis, clubbing, and edema. There's no generalized lymphadenopathy. The eye signs are absent. A local examination, inspection. It is done in sitting position. Swelling was present in the anterior aspect of the neck. It was about 8 centimeter by 5 centimeter large, butterfly shape, extending from medial border of right sternocleidomastoid muscle to medial border of left sternocleidomastoid muscle, and about 6 centimeter from symphysis menti to 1 centimeter above the manubrium sternum vertically. The lower border is not visible. The swelling appears nodular. The swelling moves upwards with deglutition. The swelling does not move up with protruding the tongue out. Then the skin over the swelling appears to be shiny and stretched. Then a curvilinear scar of about 15 centimeter healed by primary intention, visible in the lower border of the neck, extending from the medial border of the left sternocleidomastoid to the medial border of the right sternocleidomastoid. Then Pemberton sign was positive. Palpation, all findings of inspection were confirmed. There is no local rise of temperature. There is no tenderness present. The swelling was felt in anterior aspect of the neck, measuring 8 centimeter by 5 centimeter, butterfly shape, extending from the right border of right sternocleidomastoid to medial border of left sternocleidomastoid, horizontally, and about 6 centimeter from the symphysis menti to 1 centimeter above manubrium sterna vertically. The lower border was not felt. The surface of swelling is nodular. The swelling was firm in consistency. The skin was free and can be pinched. The swelling moved upwards at deglutition. The swelling is mobile horizontally. The plane of the swelling, it is done by contracting the sternocleidomastoid muscle bilaterally. It lies in the pretracheal fascia because it was moving upwards at deglutition. Then cockroach test was positive. Then the position of the trachea was central. Then carotid pus was felt on both sides. Percussion was done over the manubrium sterni. Dull note was heard. Auscultation, upper pole of thyroid gland was auscultated. No bruits heard. Systemic examination, cardiovascular system. Both S1, S2 was heard and no murmurs. Respiratory system, normal vesicular breath sounds heard in all lung areas. Central nervous system, no focal neurological deficit. Ankle reflex was normal. Perabdominal, soft, non-tender, and no organomegaly. Examination of skull and spine was normal. Provisional diagnosis, carcinoma.
Go back to your inspection. No, go back to your inspection.
First slide. That is inspection. NFL.
Next.
Next slide.
Eye signs are absent. What eye signs are absent?
So Mobius sign, Van Graaf's sign.
What are they suggesting?
So Mobius sign was loss of accommodation. So you bring the finger from far and you bring it near. Then Van Graaf's sign is the lid lag. So you keep one hand on the head of the patient and then you lower the finger and you see for the lid lag. Then there is lid retraction. Then there is Joffrey sign, that is wrinkles. Wrinkles was absent.
Wrinkling of forehead.
Wrinkling of forehead was absent.
Okay, next slide.
So eye signs of thyroid toxicosis are absent. That's
Yes,
what
sir.
I was hinting at.
What he is telling. So, anything to comment on this, sir? It is butterfly shaped, huh? Because previous surgery done, they removed thyroid. Do you think it is butterfly shaped?
It was butterfly shape one.
Smaller than 8 by 5.
Sir?
The spleen is much smaller than 8 by 5 centimeters.
I'm not able to
Now-
hear.
The
Lower
size of
body-
the spleen is much smaller than 8 by 5. 8 by 5 is a very large section.
What about
One.
lower body? Why lower body is not visible?
It may be
Yeah.
due to retrosternal extension.
You say that you are able, your deglutition, it moves up, isn't it?
Yes, sir. Even during that, the lower border couldn't.
But you have not mentioned it.
Ah.
Next slide.
Next
The
slide.
lower border is 1 centimeter above manubrium sternum, and you say lower border is not visible. Does it correlate?
Contradicting points.
Radial
That-
border and about the system will come symphysis belt and 1 centimeter above the mandible tendon, you said.
That means almost above the notch.
So, but the lower border was not, even when we asked her to drink water also. So on deglutition,
That is right accepted, but
Agree, but you should not have mentioned that 1 centimeter.
1 centimeter above mandibular sternum is wrong.
That is wrong.
that is wrong, probably. Either of these things should be wrong. So that is 1 centimeter above the mandible will not be, because it is not. He said lower body.
Do you have any closed photo of the neck? Any other photo very close to the neck?
Only we can magnify, sir.
Magnify. No, not that. Okay, proceed. Next slide. Move on.
So once lower border is, you can just tell lower border that the manubrium sternum. Don't tell 1 centimeter above, like Sriram Joshi sir highlighted it. So you can't tell both things together. Understood?
Yes.
No?
And in fact, the lower border is visible there
Yes, sir. I do
in
agree.
the picture when I magnify. Yeah.
The lower border is visible, maybe going down, but you should not tell 1 centimeter above, like you rightly told, sir. So that is wrong.
The second point is swelling moves upwards with the deglutition. There also you have to mention whether the lower body is visible or not.
Okay, yes.
okay.
That he told, even lower body is not visible. That's what you told, no, Aryan?
Yes, sir.
So 1 centimeter above will not come at all. That
Okay, sir.
becomes wrong. Positive set. Is it clearly? Is it true?
Sir?
Sign.
Sir?
Sign. You said it is
Pemberton, how will you do?
Okay. Pemberton sign, you ask her to raise the hand up to the ears and you wait for the arm up to the ears for 3 minutes and you look for veins or the facial condition.
Lift the arms and the hand, both arms should touch your ear.
Touch your ear.
Then what happens?
Facial congestion happen. Thoracic outlet.
Outlet, inlet.
Inlet, sorry. Thoracic inlet and the major veins, they get compressed.
Right. Okay. In the inspection, what else you see other than the gland?
The
Or is it-
rest of the neck.
Yes. What do you see on the left side? Something prominent. Any veins?
Mole.
Mola. Any veins?
No, sir. No veins.
No veins. Looks like a vein. Okay. Then
Okay, next slide. Sir, we'll go to next
Surrounding
slide.
surface is nodular. How is the nodule? All nodules are same size or different?
Different.
A size ranging from
Yes.
There is a small
nodular
nodule,
size.
very large
The
nodule,
range is
small nodule, and some other nodule. No?
The middle was large. The lateral well filled.
How many nodules are there?
Roughly.
Three
Right
3 to
side,
4.
left side.
You said what is the consistency? You said firm, huh?
Firm, sir.
But again, same like Sunil Joshi sir already pointed out. Again, palpation also you made the same mistake. 1 centimeter above the
Same.
mantle you said, and you are telling lower border is not filled.
No.
Can you pass your? Can you insinuate your fingers between the swelling when it moves up and the manubrium sternum? Do you have some space there?
No, sir. You couldn't feel the lower this thing at all.
But it's that's what he told, sir. Even after swallowing nutrition also, you won't get any finger in the lower border. So that point, like you rightly pointed out, that point should not be there.
Yes, sir.
But above the mantle lower border is not felt clearly. Okay, that. So next slide. Shall go to next slide, sir.
Yes, sir.
Yes, sir.
Next slide. What is Cocker's test, Aryan?
The Cocker's test. From behind you posterior medially compress the swelling. So if there's long-standing goiter, it can indicate tracheomalacia if it is positive.
Or what it means? It they have developed stridor.
There is
A wheezing sound. Strider.
So it is
lateral compression. Don't say anything else.
Lateral.
Compression that will produce a sound which is characteristic of this thing because of the already pre-existing tracheal narrowing. That is the explanation. Okay.
What are all the strap muscles?
Carotid pulse is felt normal.
Yes, sir.
Suppose if it is not felt in case with what it means, what it is called as
Berries.
Very side.
we felt equally both sides.
Yes, sir.
Why did you? Can I know why did you do that? Contracting the sternocleidomastoid muscle.
That is to identify the plane of when you contract. If it is still fixed, it means it is deep. If it moves, means it is super.
Only sternocleidomastoid?
What fascia? What fascia we are talking about?
Sir,
What fascia?
pretracheal fascia.
Pretracheal or
Some other fascia.
some other fascia?
But deep fascia, you see.
Deep fascia. What is
What
called
are the
as?
three parts?
Sir,
What
What
is
are the
called
three
as?
parts?
sorry, sir.
What is the name? Any other name?
Investing layer of
Investing layer.
That is deep fascia, no? But you want to stretch it, contract it, or you want to stretch it? Which one is correct?
Fascia cannot be contracted.
Yes.
The thyroid is above or below the fascia?
Below.
Then if you want to see whether it is this thing, what you should do? Stretch the fascia.
Yes, sir.
Stretch the cervical fascia. How do you do that?
You ask the patient to look back.
Stretch it up, lift upward. Fascia gets stretched and see whether the gland any change is there. Either it becomes prominent, less prominent, or disappears, something like that. Here you are putting, contracting the sternocleidomastoid muscle.
More than sternocleidomastoid, you have to mention about the sternohyoid and sternothyroid. They are anteriorly placed. Sternocleidomastoid is laterally placed.
strap muscle. You have to remember.
How did you check the trachea?
So trachea, the middle finger in the superior notch and the other two in the middle part of clavicle. Then you slowly descend it down and you feel the.
Are there any other methods to palpate, to examine trachea?
Yeah.
Any other way to examine the trachea?
One is palpation. You use the 3-finger test and you. It's called, what do you call that sign if your middle finger goes this way?
What that sign called as?
What do you call this?
One side.
Trail sign.
Trial.
Call a trail sign. What is the second method?
Second.
Sir has given clue. One is by palpation, he said. What is the other
One-
method then?
By inspection.
Inspection.
No, sir, by percussion.
Okay, sir. Okay.
Auscultation.
Auscultation. In old, very rarely in olden times when we had these huge ones which was causing shift, the only clue on inspection that would give us was the sternocleidomastoid becoming more prominent on one side. It will go this way. But that is not sure. That is only just a clue, that's all. So we had confirmatory and palpation. Auscultation, what is the last one? You're not sure now at all. Like palpation, you're not pakka. Auscultation, you're hearing variable noises. What is the third? Confirmatory, pakka, that you can say that yes.
X-ray.
Simple imaging, that's all. Radiology. Simplest. It's very okay. Yes.
Okay, next slide. We'll go to next slide.
Next slide.
Next slide. Subhiksha, next slide.
Because there was retrosternal extension, then otherwise resonant.
Keshav, you want to tell us something?
Aryan, did you check for laryngeal crepitus?
Sir?
Laryngeal crepitus, have we checked? What is laryngeal crepitus? Normally present, absent.
Because in this question, hoarseness of voice is there. It's very important to check laryngeal crepitus.
Laryngeal crepitus, have you heard? What is normally present, absent?
Absent.
Absent normally in the you and me. Suppose we are normal. It is present. Normally it is present.
What is laryngeal crepitus? You should know what it is first.
If you hold your larynx like this and horizontally, you feel the grating sensation. That is laryngeal crepitus. So that is normally present. With laryngeal disease, it gets fixed, so you won't be able to get it. Okay, that's what
Yes,
Professor Keshav Prasad want to inform you. Okay.
So this patient is having hoarseness of voice. It's very important to check that. Since you are telling blink, absence of laryngeal crepitus is an important sign of malignancy.
Why you want to check Brui upper pole?
So upper pole, if there's toxic and very, it's a vascular tumors and all.
Your clinical examination, general pulse is how much is your pulse? I remember.
78.
Then how do you expect it? Unless you have tachycardia, what do you call that? A classical hyperdynamic circulation. It should cross around 100, 110, 20. Then only you will have a turbulent circulation to auscultate for Brui. Understand? So
Yes, sir.
with normal pulse, why should you auscultate? Understood. Why you that upper pole?
Upper pole because superior thyroid.
Yes, superior.
Artery.
Artery?
It enters the thyroid.
Land where? Superficially or deeply? Deeply. Enter the gland superficially in front.
Yes, sir.
That's why you hear that. You hear the superior pole, okay?
It's a branch of what?
So superior thyroid external carotid.
Right from the carotid itself. Yeah, right. Next slide.
Next slide. Next slide. Subhiksha, next slide.
When are you going to mention about lymph node examination? You have not mentioned anything about the lymph node.
Lymph node is never mentioned anywhere.
Regional lymph nodes.
Thank you, sir. I was waiting for the last thing to take it.
He has come to systemic examination.
That is
Palpationally, you should
where-
mention about
examination is
trachea,
not
carotid,
complete.
lymph nodes.
Remember that one more point. No other swelling in the neck. That has to be. Any time you must mention that there is no
other swelling.
You have to specifically mention lymph nodes are not palpable or not, or palpable or not palpable. Aryan, that's very relevant, important.
Yes, sir.
Tracheal, carotid, lymph node. In addition to thyroid.
Lymph node examination is not mentioned, you have to write specifically. Other
Yes,
cell
sir.
examination, you have to specifically tell lymph nodes are palpable or not in the neck. The most important point actually, especially in this patient. Okay. So,
Yes, sir.
skull and spine, he has mentioned. Abdomen, ankle reflex, CNS, everything. Next slide.
Any swelling in the scalp, but that has to be mentioned.
No, sir.
No swelling in the scalp. You have to mention it for conclusion.
Examination of skull and spine,
No,
normal.
scalp swelling. Scalp swelling.
Scalp swelling you had mentioned specifically. It's a common
Is there any
sign.
swelling in the scalp that concludes? After lymph node, you have to say this in a sign of malignancy.
You are looking for the swelling. You have to examine the skull for the swelling. Okay.
Yes, sir.
So carcinoma thyroid, non-toxic recurrent multinodular goiter, lymphoma. So these are the differential diagnosis you have put. Justify why you think it is a carcinoma.
Because the toxic features not.
No, tell why it is. Don't tell why not there. Why
Tell
it is.
positive points first.
2 years duration, 30 years back surgery,
Family history.
recent history of compressions. What type of malignancy you think of, whether it is papillary, follicular, or anaplastic?
So most common papillary.
Okay. Okay.
First thing is age, now 67.
Age 67.
Age is 67. Then second thing is
Yes, sir.
swelling is progressive. Then she has got voice impairment,
Pressure center.
pressure symptoms, no pressure symptoms, but change of voice, hoarseness, other things. So the palpation also, you said it is firm. Is it
Yes,
firm
sir.
or hard? We don't know exactly.
But hard, I'm not sure whether it is one like us. Okay for thyroid. Any texture is okay. Consistency is okay. Thyroid carcinoma can be soft, firm, or hard. So any variable is very common in the thyroid carcinomas. So
Sir, may I ask a question? Sir, investigation.
Yes, sir.
Any swelling, Aryan, the gold standard would be an FSNAC because it's the most simplest test. Agreed. We all agree.
Yes, sir.
Possible that we can miss something in the thyroid swelling by taking FNAC.
The follicular.
Follicular what?
Carcinoma. If it is carcinoma or adenoma, you want.
Follicular carcinoma, hurdle cell neoplasm, so many are there. So you will not be able to diagnose follicular neoplasm,
Yes, sir.
carcinoma. If so, what would you want to do? What is your next investigative tool?
if it is a follicular neoplasm, what next you will do?
So biopsy.
Biopsy, true cut.
True good.
Abhishek?
Yes, sir.
Video, Abhishek.
So we can opt for biopsy, sir.
What bias?
What type of biopsy you want to do? True cut biopsy, core cut biopsy, punch biopsy, cone biopsy, excision biopsy.
Yes.
Which one you want to do? You choose. We have crossed 9. We are about nearing my. What do you want to do? It's your patient. Patient operated previously. Please remember, this is about this patient. We are not asking generally. You are not sure what it is. Sir has already asked. You said papillary carcinoma. I have argued that it is not possible. And you want to confirm. What biopsy? Just you have 10 seconds in an exam to answer.
What biopsy? You do that in thyroid?
Core needle.
Core needle. You have combined both FNAC with core cut. Okay.
You can do
Course.
Aryan, would you like to agree to Abhishek? Biopsy?
Core.
Aryan, are you agreeing? For his answer.
Yes or no? That's all.
Core cut by.
You are agreeing with him?
Core cut biopsies. Now needle.
So you want to do? Both of you want to agree with core cut biopsy? Okay. Well, we are saying that we are not agreeing to that. What? Any reason why?
What is the danger of doing core cut biopsy in the thyroid in the neck?
Any particular reason why we are not agreeing to biopsy?
What you want to do?
One, it is in the neck region. Okay. Why? Two, in this particular patient, why you don't want to do?
Can you specify here?
Just give one thing from the history. That's all. We'll get it understood that you have understood the case.
She has some symptoms of
Pressure center.
No pressure symptoms. Nothing. Some from your history.
She has what she has undergone earlier?
a thyroid surgery was done.
So if you have done a thyroid surgery 30 years ago, what are you expecting here? The normal anatomy is completely distorted.
Yes, sir.
First and foremost, the question was, would you do it in the neck? The answer is no. This is a highly vascular area. One, two, it is a closed place. A patient has come walking to your clinic with no obstruction. You put this big gun into her neck, blind. Even if you do ultrasound, still you are blind because you are not sure what is opening.
Where?
It's too dangerous.
Sure, you've seen a true cut core cut gun.
There are few studies and they said it is not adequate, it is dangerous. All studies have proved that it is not acceptable. Okay.
You clamp it and you pull, it's over. Patient develops hematoma, respiratory obstruction, you have to do a tracheostomy.
On the spot.
On the spot.
On the spot.
You have no option.
You know, all trouble. You'll never do core cut for thyroid. Aryan, okay.
So
What is the size of the true cut?
Yeah, yeah.
What is the size? Core needle, what is the size?
20,
What's the size?
You should know the size of the needle for FNAC also.
What is the size
23 to 30 FNS.
30 gauge.
of 30?
How many gauge? What gauge?
23 to 30 for FNS.
30 is two things.
30.
23 to
23 this one. Core cut, I think 14. I think, probably.
Yes, sir. It is very yes.
You will not
Just to complete it, Abhishek and Aryan, so you will not do.
both, sir.
Yeah, but you
biopsy,
need to get a diagnosis for follicular carcinoma. Only thing is you can expose this tissue to something else. There are 3 tests that is there in the book now. You should know the answer for that. DNA assay is there, and you can subject this tissue to that. Now the third question, last question from my side. Now you want to do a biopsy. Can you give us 2 conditions where you will do biopsy? Yes, thyroid. This is the thyroid swelling, but 2. We have given you 2, only 2. That's it. Nothing more than this.
Okay. Aryan, Robin, you can give the answer. There. Can you give the
Yes, sir.
Answer.
2 conditions of thyroid where you have to do biopsy to confirm your diagnosis.
If it is rapidly increasing,
Diagnosis.
Specifically, sir is telling 2 conditions. Tell us the malignancies, all the malignancies you know of.
papillary carcinoma,
Yes.
follicular, medullary, orthodox cell, anaplastic.
Anaplastic.
Anaplastic. That is the one.
Anaplastic.
Anaplastic, we need a biopsy to
Second
confirm.
one.
Second one.
Follicular.
No.
What else?
You left one more.
Medullary.
When we asked you something, you gave that as differential diagnosis first of a swelling here.
Lymphoma, you are told. No?
Lymphoma, you said no.
Lymphoma, sir.
Lymphoma.
So we can change, no problems. Yeah.
So what?
So remember quadruple assist.
Calcium or calcitonin,
Calcium, why calcium?
or maybe calcitonin you want to change it.
Calcium.
Must be calcium also. Calcium one side. Next slide. There, next slide. There. Subisha, next slide. So this is the treatment he has put actually.
No. Previous slide you said laryngoscopy. It's very important because already there is patient is having hoarseness of voice. You said no.
Yes, sir.
And then laryngoscopy is important. You just not mention and say laryngoscopy and then go to the last slide. So you expect something. We see whether there is nerve infiltration or something that what the voice change you only said no. That is the only investigation which will say something wrong with your laryngeal nerve, or let's say unilateral or bilateral.
So what Sir Manoharan sir, here they should give the carcinoma thyroid should they diagnose it, because workness of 2 year duration become last pressure symptoms last 2 weeks.
Yes, sir.
Of course, FNAC, then of course laryngoscopy is very important here. May I add on to MRI, probably CT scan, there is a controversy, still is accepted. MRI chest and neck is important because they said that retrosternal area extension is there. So that is very important to evaluate. So eventually, of course, treatment is total thyroidectomy, of course, is there. Of course, lymph node is we have to assess by imaging, and of course, what type of malignancy patient is having, and whether on that you have add on to the lymph node dissection. Now, retrosternal extension, how we'll tackle is the important thing here. So whether that will be too much for UGs. Whether we will be able to immunity from the neck, but the only thing is the hurdle here is a previous surgery may find difficult to get into. Whether you do or not be ask a thoracic surgeon to come with you to help go ahead with the surgical procedure properly. All these things have to be actually clearly thought of, which is probably a little more difficult for UGs, but this is the facts they have to remember. And radioactive therapy, eventually they have to give because it will quickly.
Not audible, sir.
Sir, then follow up. How to do follow up?
After the surgery, then you do whole body iodine scan.
Whole body. What is the prerequisite? What is the
The
TSH?
TSH should be more than 30.
30, sir.
Of course, then you have to give a therapeutic radioactive orally. You should be given orally. That's the point you have to remember. So you have to know about the carcinoma of thyroid. So, sir, there any comments on that? Meantime, I'll start my slide, sir.
Sir, I have a small doubt because he said whole body scanning. I think Manoharan sir or Joshi sir can enlighten this, because do we do whole body scan or do we do cervical?
Neck and thorax is sufficient. I don't know. Let's see if they do in thyroid. I'm not sure. I need to know.
Yes, iodine usually they expose only this. Unless your the repetitive scan after 3 months, levels of this thing are still going up.
Then
you are suspecting metastasis somewhere, then you open up.
Whole body scanning is done after total thyroidectomy.
Yes, sir, that's a
not before. After surgery, that is done, not before. So, any final comment? They have presented all the things. You have to tell. I won't comment on my students. Robin, Manoharan sir, Muthukumar sir, Keshav. Give a.
I leave it to my teachers to say, seniors.
Manoharan sir, Muthukumar.
I will type few things in the YouTube. So few questions I will type, sir, by the time.
Okay.
No, that negative history, some of the things are not warranted, sir. So if you remove those things, negative history like no history of this, that, and those you remove, I think that is more focused. So they have highlighted the positive signs and remove the other things. And all. Discussion part is okay, they are able to answer.
Yes, they presented
yes, sir. Very
more that reasoning they should be able to run. Otherwise,
yes. And the retrosternal part and 1 centimeter above the thing that was contradicting themselves. Otherwise, rest of the things were all okay, sir. Both of them did well only.
Previous surgery with the little tougher, of course. And then to the slides for the students that in the YouTube, sir. Next slide. All three butterfly shape. Next slide. Thyroid malignancy common. You remember, male is a high risk factor. Next slide. Next. That voice you should mention the chief complaint, Abhishek. Weight loss, you have told weakness, palpitation, tremor, duration, like this in the order you should mention the chief complaint. Next slide. Swelling, pain, fever, hypothyroidism, treatment, surgery, drug entry. This is what I think Muthukumar sir has highlighted. Whether you have to, whether patient is on L-thyroxine or not, that point you should do. If you specify, not specify. Give some information. So the main thing is eye signs, different eye signs. There are so many, around 20 eye signs there, but you don't record, remember all those things. Elvax, one-grade retraction, obvious sign, Joffrey sign. That's for ophthalmology. Only these things, if you remember, sufficient. All other things are mainly for MCQ. And tremor, fingers in the tongue, gait, all those things, of course, whatever mentioned here. Creeping pulse rate, while breathing, you have to remember. In the midnight, you have to check the pulse while patient is. That's the point you have to remember, especially in toxic thyroid. Next slide. This is the chart for the inspection. I'm not going to detail it. Trials method, examine the thyroid from behind, put your thumb over the occiput. Then trail sign, pemberton sign, Leahy's method, which we are not discussed. Stand in front of the patient, push the one gland to laterally and other gland posterior part become posterior lateral, and we will be able to feel the posterior part of the opposite lateral. So that is the Leahy's method you should remember. Pulsation, plane of the study already sir has discussed. Keratosis pulsation and WHO grading for goiter. The newer additional gradings of old grading, new grading also has come now. Price method, Pizzolo's method, Cocker's test, everything is discussed. The moment of the gradation also, why it why what's the reason for Berry's ligament and other things you should be able to give answer. Next slide. So other examination, oral cavity scalp examination is important, sir has already told. Percussion, auscultation, we have discussed. Lymph nodes, which you have forgotten to mention. Specifically, you have to mention regional lymph nodes, cervical lymph nodes. Other lymph nodes, if in case you think of lymph nodes. Specific examples, ankle jerk, skull, spine, other things are definitely important. Next slide. So clinical, this is exact, you'll give the diagnosis. Go back. It's a quadruple assessment. Go back. Quadruple assessment in the breast lump, triple assessment. Here, quadruple, clinical, biochemical, imaging, and FNAC, of course, cytological. So the quadruple, whereas there in breast lump only triple assessment. Clinical, sonological, FNAC, biochemical treatment, of course. Next slide. So give complete diagnosis is important. It's a movement with the deglutition. Lower body is important, butterfly shaped, and Hills method. And of course, Tanakada mustard muscle examination, contact with the mustard muscle. Next slide. Next. So this is how from behind to examine. The trials examination for different methods. Already Robin has discussed actually. Next slide. So this is a toxic thyroid, vertebral myxedema. It's a Mobius sign, and Leahy's method, trill palpation. This is the Geoffroy sign, and this is the North-Ziger sign. Have some behind there's a protection why there are not. This is Geoffroy sign. All those these are the signs you have to remember: Geoffroy, North-Zigers, and Mobius sign, Van Grief sign, Elwag sign. This is you don't have to remember all other 20 signs. That is for only academic interest and for MCQ. Leahy's method is important. Trill is important. Next slide. And of course, again, nodules, different isthmus is involved, one lobe is involved, simple goiter, multiple nodular goiter, toxic thyroid. How it looks like. Next slide. So it's a common male thyroid considered malignancy. They are high risk, remember. This is the oral cavity, lingual thyroid looks like this. This is the malignant thyroid involving the skin actually. This again with ulcer, again malignant thyroid. Next slide. Next. So remember all these things we have discussed. Thyroid steel, paradox. I'm not going to discuss that. You can read the book. It is there in my book. Paradox is important. Decline is important. Very time. Lingual thyroid. Vertebral myxedema is a misnomer. It is discussed. Abhishek. It is a misnomer. It is in toxic thyroid, not myxedema. Extra character classification. Important T3, T4, TSH. Serum calcium, calcitonin, radioactive study. Serum thyroglobulin, especially in the malignancy during follow-up period. So all these things are important factors which you have to frontal bone skull. Already we have discussed. Sir has told skull examination is very relevant in thyroid. Sir has already told, and all these things are important. Common functional status, compression, neck node, tracheal deviation, features of malignancy, retroflexion, and so on, which already we have discussed. This is put in the table actually. Next slide. So just to go through that, I'm going to detail it. Dunhill classification is the older classification. I'm not going to detail it. So this is the old classification. Still remember. Differentiated, undifferentiated, medullary lymphoma, secondary, differentiated, PCT, FCT. Next slide. Next. This is the current classification. Remember, WHO 2022 classification. This is the current one which is already which is accepted now. Follicular cell neoplasm, benign, low risk, malignant neoplasm, C cell, there is medullary carcinoma thyroid. All these things have become important. Different types, PDT, all the new entity, which is becoming more and more accepted method of classification for thyroid since 2022. This is the current standard classification for thyroid neoplasm. Remember, of course, in the exam you need to remember the classification. The simpler and easier. But this is the current accepted classification, WHO 2022 classification. Next slide. So etiology, I'm not going to detail it. Radiation, familial, genetic Cowden syndrome. Robin discussed that some mutations are included for PTC. I'm not again going to discuss different variants are there for the PCT, MCT question there. And gross, their color is black color. Brown or black color is the content in the papillary carcinoma thyroid. Often asked MCT question. Remember, that section is brownish or blackish. And some homo bodies, orphan nuclear, very typical. Tall type is aggressive. Spread mainly lymphatic and later extrathyroid becomes aggressive. And firm, hard, soft, cystic, multinodal, everything is possible. And distal front is possible. So all these things are the important features of thyroid. I want to detail it by just putting the next slide. So Wooler classification is for PCP, remember, primary, intrathyroidal, extrathyroidal. And investigations, again, we have discussed that thyroids is important thing you have to remember. Liquid imaging report data system here 1 to 5. Whereas biroids is 1 to 6, I think. And treatment, total thyroidectomy, no thyroidectomy, sir. No partial, no subtotal. Remember, current accepted terminology is the total thyroidectomy with the lateral neck dissection with the suppressed L-thyroxine. Role of hemithyroid in a small thyroid, small nodule less than a centimeter, hemithyroid may be the accepted thing. These are the prognostic scorings which you have to remember for PCT. PCT is a commonly asked main question. Remember, exam they will ask. Next slide. Next. So, back follicular carcinothyroid, second common. I'm not going to detail it. All the things we have discussed. Cider, hoarseness, dyspnea, very sign, finish inconclusive. Already Robin has discussed it. Inconclusive, but no true biopsy. Frozen section biopsy is possible, but still not accurate. If you do thyroidectomy, then go ahead with the further thing. So treatment is mainly radioactive therapy. TSH level should be more than 30 units before doing the radioactive study or therapy. That's important. Next slide. So differential thyroid carcinoma, all the classifications you have to remember. Now age factor is 55. Olden day before 2018, it was 45 years. Now it is changed. Now remember FCT, radio imminent ablation precautions during radiotherapy. It is there in my book. Arthal cell carcinoma. Remember, no chemotherapy for thyroid. So central compartment dissection, whether you do level 6 nodes, completion thyroidectomy meaning, and problems in suppressive cell thyroxine, cardiac osteoporosis, and management metastatic manage. All these things are the newer for possible investigations. After surgery, you will do PET CT or whole body scanning, not before thyroidectomy. That's the point which you have to remember. Next slide. Next, Subiksha. Next. So anaplastic carcinoma, undifferentiated, you remember. I'm not going to very, very aggressive. Remember, very sign positive. Strider test, not with the Cocker's test. Strider test it is. And it's always stage 4. Remember, anaplastic carcinoma, there is no stage 1, 2, 3. It's always stage 4. The MCT question, remember. Carcinoma thyroid, all these things are the different. It is not directly from the thyroid, from the C cells. So calcitonin is the important tumor marker. MN2 syndrome may be the association. And screening of all family members are important. Again, look for pheochromocytoma, diarrhea, and so on. So next slide. Examine abdomen. So in the medullary carcinothyroid, abdomen exams is a very, very important. So this is the malignant thyroid. Next slide. Next. So MCT again, calcitonin, CEA are the markers. Go back. So all these things I'm not going to detail it. If it's useful for MCT, adriamycin. And there is no suppressive dose, only maintenance. In family members, we have to do the prophylactic thyroidectomy. So in MCT, prophylactic thyroidectomy is accepted in family members if their calcitonin is higher. That's the point you have to remember. Next slide. Next. So this is the neck dissection, central node, lateral node, which levels are there for thyroid specifically. Level 2A, 3, 4. These are the things. These are the things which are very important. 2A, 3, 4, and central level 6 and central compartment. There's the meaning, everything you have to know in central compartment. Thyroid. Next slide. So this is the thyroid, total thyroidectomy with the lymph node dissection in a malignant thyroid. Remember, Emil Theodore Cocker, all of you know, is the father of the thyroid surgery. He got Nobel Prize, first surgeon to get Nobel Prize. He was from Switzerland, Bern. Did lot extensive work on thyroid. So we need to remember him whenever we discuss about the thyroid. There's a lot Cocker's test, Cockerization, Cocker's incision, Cocker's wean, Cocker's method of shoulder joint dislocation reduction. So although so many Cocker's instrument is there. So many things he has given to our surgical field. That's why you have to remember this great person, Emil Theodore Cocker. Next slide. Next. So that is briefly about carcinoma thyroid. At least this much students should know. UG should know when they present a carcinoma thyroid case of theory or MCQ. They will ask so many things, whatever I mentioned, or exam they should know about the carcinoma thyroid. My 8th edition book is available currently. It's a newer edition. Sir has written a foreword for that. I am really happy for that. Thankful to sir. And with the MCQ booklet is there with that. My website, I request everybody to join. Everybody subscribe. It's free actually, and so that already around 450 lectures are there. Around 25 live sessions regular is there. Of course, daily MCQs are already around 500 MCQs are there in the my website. Please go through that. Students can learn whenever they want instead of seeing unnecessary videos. You can go through my videos and it's free. You can learn surgery easily and comfortably actually. So I thank Manoharan sir for joining. Muthukumar sir, very much. Robin made my day. We have joined. Sunil Joshi sir had some problem. I really appreciate. Keshav always is there with me, my good friend. Not only for the joining this one, he is there for any my problems with my surgeries. Also, he'll come and help me. He's a great surgeon, and I'm thankful to him always. The students, they presented well. Aryan and Abhishek, my students, they were in my unit. They read, of course, they presented well. Of course, difficult case. Thank you, sir. Muthukumar, sir. Robin, I have someday this month or somewhere, I can definitely appreciate if your student present cases.
Yes.
Platform.
So I'll try. This month I'm a little bit tight, but I'll ask the students. I plan to fix them actually. Timetable we can set.
Because want to have this platform to other colleges also, everybody.
Yes.
So let it be accessible to everybody. That is the only mode. And sir, Manoharan sir, thank you very much for joining. Robin, very much. Muthukumar sir, thank you very much.
Thank you, sir.
Keshav, Sunil, of course, students, they have presented very well, and all viewers, please have a comment about the sessions and opinions. Always accept. I'll accept any criticism and comments. Definitely, I will accept. And thank you, sir, for joining. We'll have a good session in 10 days. Again, please, sir, request you to join. And this day is sir told Sunday don't want yesterday cricket was there. So today we'll have the session. Manoharan sir. Definitely good idea to have today. Robin, thank you very much, Keshav. So in 10 days we'll have one more. Probably Muthukumar sir. Sir, I'll discuss the Muthukumar sir. Let's say the student next session maybe in 10 days.
So I am already at it. I have informed some 3-4 colleges, sir.
Yes, sir. If they are willing to,
Yes, sir. I already told them by next month onwards they will start, sir, one by one.
Sir, if they want their college students, final year students, if they want to definitely.
In our own college students also, I am motivating.
Yes, sir. Please, definitely.
So
Presentation and